Hello and welcome, and today we are covering hematologic emergencies. These are the cases where the diagnosis lives in a laboratory value rather than a vital sign, where the patient can look deceptively well while their blood is either clotting everywhere or refusing to clot at all. Some of the conditions in this lecture are rare enough that you may see only a handful in a career, but they are the ones where recognizing the pattern in the first 15 minutes decides whether the patient survives. Let's work through them together. Here are our objectives. First, recognize the hematologic disorders that kill quickly. Second, start evidence-based resuscitation before the diagnosis is confirmed, because in this field, waiting for the confirmatory test is often the fatal error. Third, choose the right disposition. We will cover hemolytic disorders, the coagulopathies, hematologic and oncologic emergencies, thrombotic disease, and transfusion reactions. Throughout, 4 priorities repeat: early recognition of a pattern, thoughtful interpretation of the laboratory panel, correct use of blood products, and timely hematology consultation. And hold on to this idea: stabilize while the diagnostic testing is still running. The plasma exchange, the factor concentrate, the antibiotic, these get started on clinical suspicion, not on a returned result. Acute hemolytic transfusion reaction is immune-mediated destruction of transfused red cells, almost always from ABO incompatibility, and almost always from a clerical error, the wrong unit to the wrong patient. It happens during or shortly after the transfusion, and the presentation is dramatic. Fever, chills, flank pain, hypotension, dark hemoglobinuria, and diffuse oozing from IV sites as disseminated intravascular coagulation begins. In an anesthetized or intubated patient, unexplained hypertension with bleeding may be the only clue. The first move is to stop the transfusion immediately. Not slow it, stop it, and disconnect the tubing while keeping the IV line open with normal saline. Notify the blood bank at once and return the unit, because another patient somewhere may be receiving the wrong product right now. Send a complete blood count, chemistries, coagulation studies, and a direct antiglobulin test, and check haptoglobin and a urinalysis. Then resuscitate. Aggressive fluids to maintain urine output and protect the kidneys from free hemoglobin, and treatment of shock and coagulopathy as they develop. Never restart that unit. Significant hemolysis, shock, or organ dysfunction earns an ICU bed. Autoimmune hemolytic anemia is autoantibody-mediated destruction of red cells, and patients present with fatigue, jaundice, dark urine, dyspnea, and tachycardia, with the hemolysis panel showing elevated bilirubin and lactate dehydrogenase, low haptoglobin, an elevated reticulocyte count, and a positive direct antiglobulin test. The critical distinction is warm versus cold. Warm disease, mediated by immunoglobulin G, is the common form, and corticosteroids are first line. Prednisone at roughly 1 mg per kilogram daily. Cold agglutinin disease, mediated by immunoglobulin M, responds poorly to steroids. Those patients need aggressive warming, warmed fluids and blood products, and avoidance of cold exposure, with rituximab as directed therapy. Now the pearl that matters at 3 in the morning. Cross-matching is difficult in these patients because the autoantibody reacts with everything on the panel. Do not let that delay a life-saving transfusion. Work with your blood bank, accept the least incompatible unit, and transfuse the patient who is hemodynamically unstable or has end-organ ischemia. Evaluate for secondary causes such as lymphoma, lupus, infection, and drugs. Admit for symptomatic anemia or ongoing hemolysis. Vaso-occlusive crisis is microvascular occlusion by sickled cells producing ischemic pain and organ injury. The patient reports severe extremity, chest, or back pain, often familiar to them and often described by a number they know well from experience. Believe them. These patients are chronically undertreated and frequently mislabeled as drug-seeking, and that bias directly worsens outcomes. Give rapid, weight-based opioid analgesia within 30 minutes of arrival, reassess every 15 to 30 minutes, and redose until the pain is controlled. Avoid meperidine, which accumulates a neurotoxic metabolite. Add a nonsteroidal agent when renal function permits. Hydrate at maintenance rates orally or intravenously, but do not flood these patients because volume overload precipitates acute chest syndrome. Give oxygen only when the patient is actually hypoxemic. It does not treat pain. Screen every single one of them for the complications hiding behind the pain. Fever, hypoxia, a new infiltrate, focal neurologic findings, priapism, and splenic sequestration. Provide incentive spirometry for anyone with chest or back pain. Discharge when pain is controlled and no complication is present. Admit for refractory pain, hypoxia, or organ dysfunction. Acute chest syndrome is a new pulmonary infiltrate with respiratory symptoms in a patient with sickle cell disease, and it is among the leading causes of death in this population. Expect fever, chest pain, cough, dyspnea, hypoxemia, and a new opacity on the chest radiograph, and know that it often develops 1 to 3 days after admission for a pain crisis driven by splinting, hypoventilation, opioids, and fluid administration. The cause is a mix of infection, fat embolism from infarcted marrow, and in situ sickling, so treat all of it. Give oxygen to keep saturation comfortably above 95%. Start broad antibiotics that cover both typical and atypical organisms, ceftriaxone plus azithromycin or your local equivalent, because mycoplasma and chlamydophila are disproportionately common here. Provide adequate analgesia so the patient can breathe deeply, but watch for oversedation and use incentive spirometry aggressively. It genuinely prevents progression. Transfusion is the disease-specific therapy. Simple transfusion for moderate disease and exchange transfusion for severe or rapidly worsening hypoxemia, arranged urgently with hematology. Everyone is admitted. Respiratory failure or exchange transfusion means the ICU. Disseminated intravascular coagulation is systemic activation of the clotting cascade. The body clots microscopically everywhere, consumes its platelets and factors doing it, and then bleeds. The classic patient is septic, oozing from every puncture site with petechiae and hypotension, and a panel that tells the whole story. Prolonged prothrombin time and international normalized ratio, prolonged activated partial thromboplastin time, falling platelets, low fibrinogen, and a markedly elevated D-dimer. Of those, the falling fibrinogen with a rising D-dimer is the most specific pattern. Here is the governing principle. You cannot fix this coagulopathy while the trigger is still running. Treat the underlying cause. Antibiotics and source control for sepsis, delivery for obstetric causes, management of the malignancy or trauma. Replace products based on bleeding and laboratory values, not on numbers alone. Platelets for thrombocytopenia with hemorrhage, fresh frozen plasma for prolonged clotting times. Cryoprecipitate when fibrinogen falls below about 150 milligrams per deciliter and packed red cells for anemia. Activate massive transfusion when hemorrhage is severe. Recheck the panel frequently because it moves fast. ICU admission. Immune thrombocytopenia is autoimmune destruction of platelets, and the defining feature is that it is isolated. The platelet count is low, sometimes profoundly so, while the white count, hemoglobin, and smear are otherwise normal. Patients present with petechiae, mucosal bleeding, gum bleeding, and easy bruising, typically with counts below 30,000 per microliter. That word isolated is doing critical work. If you see thrombocytopenia with anemia and schistocytes on the smear, you are not looking at this disease. You are looking at a thrombotic microangiopathy, and the treatment is entirely different. Check the smear yourself. Management depends on bleeding and severity. Corticosteroids or intravenous immunoglobulin for clinically significant hemorrhage or severe thrombocytopenia, with immunoglobulin acting faster when you need a rapid rise. Platelet transfusion is reserved for life-threatening bleeding, and even then, it is given alongside definitive therapy, because transfused platelets are destroyed just as quickly as the patient's own. Consult hematology. Discharge only the stable patient with mild disease and reliable follow-up. Admit anyone with significant bleeding. Thrombotic thrombocytopenic purpura is a deficiency of the enzyme ADAMTS13, which normally cleaves von Willebrand factor multimers. Without it, those multimers shred red cells and consume platelets across the microcirculation. The classic teaching describes a pentad, fever, altered mental status, thrombocytopenia, hemolytic anemia, and renal injury. But I want you to unlearn waiting for it, because the full pentad appears in a small minority of patients, and by then many are dying. 2 findings are enough to act on: thrombocytopenia plus microangiopathic hemolytic anemia with schistocytes on the smear and a high lactate dehydrogenase without another explanation. Do not wait for the enzyme assay to result. Call hematology emergently and arrange plasma exchange, which is the treatment that dropped mortality in this disease from roughly 90% to under 20%. If exchange will be delayed, give plasma infusion as a bridge. Add high-dose corticosteroids and caplacizumab where available. Critically, avoid prophylactic platelet transfusion. It feeds the microthrombi, reserving it for life-threatening hemorrhage alone. Every hour of delay costs lives. ICU admission. Hemophilia with major bleeding means life-threatening hemorrhage in a patient congenitally deficient in factor VIII, which is hemophilia A, or factor IX, which is hemophilia B. Presentations include hemarthrosis, intracranial hemorrhage, an expanding neck or retroperitoneal hematoma, and prolonged bleeding after trauma. Here is the single most important behavior in this slide. Give factor first. Do not wait for the CT scan. Do not wait for hematology to call back. Do not wait for the laboratory. If a hemophilia patient with a head injury walks in, factor goes in before they go to the scanner. For major bleeding, you are aiming to restore activity to about 100%, which is roughly 50 units per kilogram of recombinant factor VIII, or 80 to 120 units per kilogram of recombinant factor IX, and patients often carry a card or know their own dose, so ask them. If the patient has inhibitors, factor replacement will not work, and you need a bypassing agent such as activated prothrombin complex concentrate or recombinant factor 7A. Tranexamic acid helps with mucosal and dental bleeding, but never substitutes for factor. Replace before any invasive procedure. Admit ICU for critical bleeding. Anticoagulant-associated major hemorrhage is now an everyday emergency. Intracranial bleeding, gastrointestinal hemorrhage with hypotension, or a retroperitoneal hematoma in a patient on warfarin or a direct oral agent. Stop the drug, activate your institutional hemorrhage protocol, and reverse by mechanism. For warfarin, give 4-factor prothrombin complex concentrate dosed by weight and international normalized ratio plus intravenous vitamin K, 10 milligrams infused slowly, and both are required because the concentrate works within minutes but wears off in hours, while vitamin K takes hours to work and then sustains the correction. Fresh frozen plasma is a second-line substitute. It is slower, requires large volumes, and corrects less completely. For dabigatran, the reversal agent is idarucizumab. For the factor Xa inhibitors, apixaban and rivaroxaban, and Exanet alpha is the specific agent where available and appropriate, with prothrombin complex concentrate as the practical alternative. And be aware that andexanet carries a real thrombotic risk. Ask when the last dose was taken. Recent ingestion may also justify activated charcoal. Transfuse products as bleeding dictates. Rapid reversal saves lives. ICU with specialty consultation. Febrile neutropenia is defined by a single temperature at or above 38.3 degrees Celsius or a sustained temperature at or above 38 degrees for at least an hour in a patient with an absolute neutrophil count below 500 per microliter or expected to fall below that. The typical patient is on chemotherapy, arriving with fever, chills, and malaise, and almost no localizing findings, because without neutrophils there is no pus, no infiltrate, no fluctuance. The absence of an obvious source is not reassurance, it is the disease. Treat this as sepsis until proven otherwise. Draw blood cultures, including from every indwelling catheter lumen, plus a complete blood count, chemistries, and lactate, but do not let culture collection delay drugs. Broad-spectrum anti-pseudomonal antibiotics go in within 60 minutes. Cefepime, piperacillin, tazobactam, or meropenem. Add vancomycin only for a specific reason. Hemodynamic instability, suspected catheter infection, skin or soft tissue infection, known resistant colonization, or pneumonia. Skip the rectal examination and rectal temperatures to avoid seeding bacteremia. Admit everyone. ICU for septic shock or organ dysfunction. Time to antibiotics is the metric that saves these patients. Hyperleukocytosis with leukostasis is a marked elevation in white cells, often above 100,000 per microliter, and typically in acute leukemia, especially the myeloid type, where the blasts are large and sticky enough to plug the microcirculation. The symptoms are those of sludging in the two organs that tolerate it least, the lungs and the brain. Expect dyspnea and hypoxemia, confusion, headache, visual changes, and retinal hemorrhages on fundoscopy. Respiratory or neurologic symptoms in a patient with a very high white count constitute an emergency, not a laboratory curiosity. Start aggressive intravenous fluids to reduce viscosity. Then a counterintuitive point. Avoid transfusing packed red cells before cytoreduction unless the anemia is truly critical, because adding red cells raises whole blood viscosity and can precipitate deterioration. Call hematology urgently for cytoreduction with hydroxyurea, induction chemotherapy, and leukapheresis in selected symptomatic patients, recognizing that apheresis is a temporizing measure whose survival benefit is not established. Anticipate and treat tumor lysis syndrome at the same time, since cytoreduction triggers it. ICU admission. Tumor lysis syndrome is the mass death of malignant cells, dumping their contents into the bloodstream, producing hyperkalemia, hyperphosphatemia, hyperuricemia, and consequent hypocalcemia. It classically follows chemotherapy in a bulky, chemosensitive tumor, but it can occur spontaneously in aggressive leukemias and lymphomas. The patient presents with weakness, cramps, arrhythmias, and acute kidney injury. Put them on continuous cardiac monitoring immediately because hyperkalemia is what kills first. Treat it exactly as you would any other hyperkalemic emergency, with calcium to stabilize the myocardium, insulin and glucose to shift, and dialysis for refractory disease. Give aggressive intravenous hydration to maintain urine output. Routine urinary alkalinization is no longer recommended since it worsens calcium phosphate precipitation. For urate control, allopurinol is preventive, while rasburicus rapidly destroys existing uric acid in high-risk patients, and it is contraindicated in glucose 6-phosphate dehydrogenase deficiency, where it causes severe hemolysis and methemoglobinemia, so screen at-risk patients. Here is the subtle trap. Do not correct asymptomatic hypocalcemia, because giving calcium in the face of high phosphate drives precipitation into tissues. Treat calcium only for symptoms or arrhythmia. Involve nephrology early for dialysis, ICU, or monitored admission by severity. Superior vena cava syndrome is obstruction of that vessel, most often by thoracic malignancy such as lung cancer or lymphoma, and increasingly by indwelling catheters and pacemaker leads. The patient describes facial and upper extremity swelling, dyspnea, and cough, made worse by lying flat or bending forward, with distended neck and chest wall veins on examination. Most cases are urgent rather than immediately life-threatening, and that reframing matters. There is usually time to make the tissue diagnosis, which drives definitive treatment. The exceptions are the two that demand immediate action: airway compromise from laryngeal or tracheal edema and cerebral edema with altered mental status. Elevate the head of the bed, give oxygen as needed, and place intravenous access in the lower extremities rather than the swollen arms, since upper body infusions drain poorly. Obtain contrast-enhanced chest CT in the stable patient to define the obstruction and its cause. Consult oncology, and reserve corticosteroids for steroid-responsive tumors such as lymphoma, where premature dosing can obscure the biopsy. Endovascular stenting relieves severe symptoms rapidly. Admit ICU for airway compromise. Hyperviscosity syndrome occurs when the blood itself becomes too thick to move through capillaries, most often from the immunoglobulin M paraprotein of Waldenstrom macroglobulinemia, and also from marked polycythemia or extreme leukocytosis. The classic triad is mucosal bleeding, visual disturbance, and neurologic symptoms: headache, dizziness, confusion, and in severe cases, seizures or coma. Look in the eye because the fundoscopic examination is diagnostic gold here. Dilated, segmented retinal veins with the appearance of sausage links, along with hemorrhages and papilledema. Start intravenous hydration to reduce viscosity while you arrange definitive therapy. For paraprotein-driven disease, urgent plasmapheresis removes the offending immunoglobulin and reverses symptoms quickly. For polycythemia, therapeutic phlebotomy is the answer. For leukostasis, cytoreduction. Call hematology immediately. And carry over the same warning from the previous discussion. Avoid transfusing red cells before viscosity is reduced unless absolutely necessary, because that raises viscosity further and can convert a stable patient into a stroke. Admit ICU for neurologic or cardiorespiratory compromise. Deep vein thrombosis is acute thrombus in the deep venous system, usually the lower limb. The presentation is unilateral leg swelling, pain, warmth, and erythema, frequently with a provoking factor: recent surgery, immobility, malignancy, pregnancy, or hormone therapy. Diagnose with compression ultrasonography using the Wells score and D-dimer to decide who needs imaging. A low probability patient with a negative D-dimer needs nothing further. Before treating, assess bleeding risk deliberately. Recent surgery, active bleeding, severe thrombocytopenia, and intracranial pathology all change the calculus. Then anticoagulate. A direct oral anticoagulant is standard for most outpatients. Low molecular weight heparin is preferred in pregnancy and in many cancer patients. Unfractionated heparin is reserved for renal failure or when procedures are anticipated. Reserve catheter-directed thrombolysis for limb-threatening disease. Phlegmasia ceruleus dolens with a swollen, dusky, painful limb is a vascular emergency. Always examine for concurrent pulmonary embolism, since many of these patients already have clot in the lungs. Discharge low-risk patients with reliable follow-up. Admit extensive thrombosis, high bleeding risk, or significant comorbidity. Pulmonary embolism is thrombotic obstruction of the pulmonary arterial circulation, and it presents as sudden dyspnea, pleuritic chest pain, tachycardia, hypoxemia, or syncope, with syncope being a particularly ominous presentation because it implies a large clot burden. Give oxygen, then risk stratify, because in this disease, stratification is the treatment plan. Estimate pretest probability with Wells or clinical gestalt. Apply the PERC rule only when probability is already low, use D-dimer in the low and moderate groups, and go to CT pulmonary angiography when suspicion is high or the D-dimer is positive. Anticoagulate unless contraindicated, and start before imaging when suspicion is high and bleeding risk is acceptable. Then divide patients by hemodynamics and right ventricular function. The hypotensive high-risk patient gets reperfusion, systemic thrombolysis with alteplase or catheter-based therapy, and goes to the ICU. The normotensive patient with right ventricular strain or a positive troponin is intermediate risk, gets anticoagulation with close monitoring and a rescue plan, and is admitted. The low-risk patient with a normal right ventricle may be discharged on an oral agent with reliable follow-up. Cerebral venous sinus thrombosis is clot in the dural venous sinuses, obstructing venous drainage and raising intracranial pressure. It is the diagnosis you miss because you were not thinking of it, so think of it in the patient whose headache does not fit any usual pattern. A progressive positional or thunderclap headache with normal initial imaging, particularly in a young woman who is pregnant, postpartum, on oral contraceptives, or has a thrombophilia, and in patients with recent head and neck infection or dehydration. Findings include focal deficits that cross arterial territories, seizures, papilledema, and altered mental status. A non-contrast head CT is often normal or shows only a venous infarct with hemorrhage, so the diagnostic tests are magnetic resonance imaging with venography or CT venography. Now the counterintuitive rule: anticoagulate these patients even in the presence of hemorrhagic venous infarction. The hemorrhage is caused by the venous congestion, so treating the clot treats the bleeding. Withholding anticoagulation is the mistake. Treat seizures, manage intracranial pressure, and involve neurology. Admit ICU for severe neurologic impairment. Heparin-induced thrombocytopenia is a paradox worth remembering, an antibody-mediated reaction to heparin that lowers the platelet count and simultaneously makes the patient clot. Antibodies form against platelet factor IV bound to heparin, and the resulting complexes activate platelets en masse. The signature is a platelet count that falls more than 50%, typically 5 to 10 days after heparin exposure, sooner if there was prior exposure, accompanied by new venous or arterial thrombosis. Bleeding is not the problem here, clotting is. Management begins by stopping every source of the drug, including flushes and coated catheters. Calculate the 4T score to gauge probability, and send immunoassay testing with a functional confirmatory assay. But for a moderate or high score, start treatment before results return. That treatment is a non-heparin anticoagulant, such as argatroban or bivalirudin, at full therapeutic dose, because these patients are thrombosing. 2 prohibitions. Never give platelet transfusions unless there is life-threatening hemorrhage, and never start warfarin until the platelet count has recovered, because early warfarin precipitates venous limb gangrene. Consult hematology and admit. Catastrophic antiphospholipid syndrome is the fulminant form of that disorder. Widespread small vessel thrombosis producing multi-organ failure over days. It is rare, and it is lethal, with historical mortality near 50%. The patient develops some combination of acute kidney injury, stroke, respiratory failure, skin ischemia or lividu, and thrombocytopenia, often in someone with known lupus or prior clotting, and often triggered by infection, surgery, pregnancy, or abrupt withdrawal of anticoagulation. Ask about that history because the trigger is frequently something we did. Recognizing the pattern is the hard part. Think of it when a patient is failing multiple organ systems at once with thrombocytopenia and a thrombotic history. Management is aggressive and multimodal. Resuscitate in the ICU. Start therapeutic anticoagulation with heparin when bleeding risk permits. Give high-dose corticosteroids and add plasma exchange, intravenous immunoglobulin, or both in consultation with hematology and rheumatology. Treat any precipitating infection vigorously. Early multidisciplinary management is what improves survival here, so make the calls early rather than after the second organ fails. Aplastic anemia is bone marrow failure, a hypocellular marrow producing pancytopenia across all 3 cell lines. Patients arrive with fatigue and pallor from anemia, recurrent infection and fever from neutropenia, and mucosal bleeding or petechiae from thrombocytopenia. The clue that separates this from a consumptive process is the reticulocyte count. It is inappropriately low because the marrow is not making anything. Emergency management is directed at the consequences rather than the cause. Stabilize the airway, breathing, and circulation. Transfuse red cells for symptomatic anemia and platelets for bleeding or severe thrombocytopenia, and when the patient is a transplant candidate, use irradiated and leukoreduced products and avoid family donors. Any fever in this patient is febrile neutropenia until proven otherwise. So draw cultures and give broad-spectrum anti-pseudomonal antibiotics within the hour. And remember that without neutrophils, the usual signs of infection are muted, so a modest fever may be the only warning of overwhelming sepsis. Use protective isolation. Get hematology involved urgently, since definitive therapy is immunosuppression or transplant. Admit ICU for sepsis, severe hemorrhage, or instability. Hemophagocytic lymphohistiocytosis is a hyperinflammatory syndrome in which the immune system activates without an off switch. Macrophages and lymphocytes proliferate and consume blood cells. It is triggered by infection, especially Epstein-Barr virus, by malignancy, and by autoimmune disease. Suspected in the patient with persistent high fevers who is not improving on antimicrobials, with hepatosplenomegaly, pancytopenia, transaminitis, elevated triglycerides, low fibrinogen, and a striking hyperferritinemia. That last value is your best clue in the emergency department. A ferritin in the thousands and especially above 10,000 micrograms per liter should immediately raise the question because almost nothing else drives it that high. This condition is frequently misdiagnosed as refractory sepsis, and the distinction matters because the treatment is immunosuppression rather than more antibiotics. Provide aggressive supportive care. Continue broad antimicrobials until infection is excluded and consult hematology urgently. Corticosteroids and disease-specific therapy such as etoposide are directed by specialists, and untreated disease is rapidly fatal. Admit to the ICU or a monitored hematology service. Massive transfusion protocol is structured resuscitation with balanced blood components for life-threatening hemorrhage. Trauma, obstetric hemorrhage, gastrointestinal bleeding, ruptured aneurysm. The core lesson of the past 2 decades is that we resuscitate exsanguinating patients with blood, not with crystalloid, and in a balanced ratio approximating whole blood, red cells, plasma, and platelets at 1 to 1 to 1, or whole blood where available. Activate early because the protocol's value is in the logistics. It keeps products flowing without repeated phone calls. Give tranexamic acid within 3 hours of injury, ideally within the first hour, since giving it late offers no benefit and may cause harm. Then manage the metabolic consequences, which is where these resuscitations are quietly lost. Warm every product and the patient, since hypothermia paralyzes the clotting cascade. Replace calcium because citrate in stored blood chelates it, and hypocalcemia impairs both clotting and cardiac contractility. Keep fibrinogen above about 150 milligrams per deciliter with cryoprecipitate. Follow base deficit and lactate. Prevent the lethal triad of hypothermia, acidosis, and coagulopathy, and remember that only definitive source control stops the bleeding, ICU or operating room accordingly. Let's consolidate into the pearls worth carrying out of this room. Thrombotic thrombocytopenic purpura. Thrombocytopenia plus schistocytes with no other explanation means arrange plasma exchange now. The enzyme assay confirms a diagnosis you have already treated. Febrile neutropenia, antibiotics within 60 minutes, cultures alongside rather than before, and no source found is the expected finding, not reassurance. Anticoagulant-associated hemorrhage. Reverse immediately and by mechanism. Prothrombin complex, concentrate with vitamin K for warfarin, idarucizumab for dabigatran, andexanet or concentrate for the factor Xa agents. Sickle cell disease, acute chest syndrome kills, so look for it in every patient with chest pain, hypoxia, or fever, and treat with oxygen. Antibiotics covering atypicals, incentive spirometry, and transfusion. Disseminated intravascular coagulation. Replace consumed products while relentlessly treating the trigger, because the coagulopathy will not resolve until the underlying disease does. Across all of these, the theme is identical. Act on the clinical pattern and let confirmation arrive afterward. To close, hematologic emergencies reward pattern recognition and punish hesitation. Recognize the syndrome early. give blood products with intention rather than reflex, reverse coagulopathy without delay, and get hematology on the phone sooner than feels necessary. These 4 behaviors change outcomes more than any test we order. The references behind this talk are Tintinalli, Rosen, and the American Society of Hematology guidelines, and I would encourage you to build protocols for the time-critical conditions we discussed, so the right sequence happens automatically at 3 in the morning when the resources are thin. Multidisciplinary care is not a formality in this field, it is the therapy. Thank you for your attention.